A 28-year-old female is referred with 3-month history of tiredness and weakness. On examination, her pulse is 82 beats per minute, blood pressure is 128/72. No specific abnormalities are evident on examination of the cardiovascular, respiratory, abdominal, or neurological systems. Serum sodium is 142, potassium 3, urea 4.2, creatinine 82 micromoles. So it is normal. Chloride is 73 millimole per liter. It is low. Plasma glucose is normal. Urine chloride is 60 millimoles per liter. So which of the following is the likely diagnosis? First is non-classical congenital adrenal hyperplasia. Second is drug ingestion. Third is Bartter syndrome. Fourth is conn syndrome. And fifth choice is liddle syndrome. So what is your answer? So coming to the question once again. So this is a 28-year-old female with a 3-month history of tiredness and weakness, which is most likely due to her hypokalaemia. Her potassium is 3 millimoles per liter. And on examination, she is normotensive. Blood pressure is 128/72. There is no other findings in cardiovascular, respiratory, or anything is there. And which of the following is, and the findings, other significant finding is serum potassium is low, urine chloride is 60, and serum chloride is 73. So that means hypochloremia is there. So patient has hypokalemia with hypochloremia. So which of the following is the likely diagnosis? Non-classical congenital adrenal hyperplasia, drug ingestion, Bartter syndrome, conn syndrome, and liddle syndrome. So we will come to them one by one. So what is among these, which of the diseases will have hypertension? This patient is a normotensive. So in non-classical congenital adrenal hyperplasia, conn syndrome, and liddle syndrome, there is hypertension. So all these choices are out. So what is conn syndrome? Conn syndrome is mineralocorticoid excess. Usually it is a mineralocorticoid secreting tumor. So mineralocorticoid is secreted from the outermost layer of the adrenal gland, that is zona glomerulosa. Inside that there is zona fasciculata, and innermost layer is zona reticularis. Zona glomerulosa, zona fasciculata, and zona reticularis. The zona glomerulosa, that is the outer layer, secretes mineralocorticoids. The middle layer secretes glucocorticoids, that is cortisol, and the innermost layer secretes sex hormones. So in conn syndrome, what you will get? What is the effect of mineralocorticoid on sodium, potassium, and blood pressure? It will cause, in the distal convoluted tubule, in the distal part of it, it will cause loss of H+, that is acid, and loss of potassium. And also it will cause retention of sodium. So because of these effects, because of the effect of mineralocorticoid, there is loss of potassium. So patient will be having hypokalemia. There is loss of H+. So patient will be having metabolic alkalosis. When acid is gone, patient will get alkalosis. So in conn syndrome, then sodium retention will cause hypertension. So patient if it was conn syndrome, patient would have had all these findings. Patient would be hypertensive. Second one is Liddle syndrome. Liddle syndrome is also called apparent mineralocorticoid excess. That is, the findings and features are similar to this conn syndrome, and it is due to overactivity of the epithelial sodium channel in the kidney. So it is called ENaC, capital E, sodium channel, that is NaC. C is capital. So ENaC is epithelial sodium channel. So that abnormality or overactivity of epithelial sodium channel will result in excessive loss of potassium, H plus, and retention of sodium. And it will result in metabolic alkalosis, hypokalaemia, and hypertension. So that is Liddle syndrome. That also is unlikely. In congenital adrenal hyperplasia, definitely you will get hypertension. Then only two more choices are left. One is Bartter syndrome and the other one is drug ingestion. Bartter syndrome means what? In Bartter syndrome, there is abnormality of sodium potassium 2-chloride channel. So what it will cause? Sodium potassium 2-chloride channel is present in the thick ascending limb of loop of Henle. It is important for reabsorption of sodium, potassium, and 2-chloride. If you remember the picture of a nephron, you can see from the glomerulus, the glomerular filtrate is formed, which will reach the Bowman space, and it flows through the proximal convoluted tubule, then descending limb of thin descending limb of loop of Henle, then the loop, and then it ascends thick ascending limb of loop of Henle, distal convoluted, then it is distal convoluted tubule. So whatever is filtered by the glomerulus is called glomerular filtrate. When it is reabsorbed, and whatever is required by the body and whatever is not required by the body, everything is filtered by the glomerulus. And in the tubules, whatever we need, whatever is needed by the body is reabsorbed. So that way, in the thick ascending limb of loop of Henle, it is impermeable to water. So what it will do? It will cause, it has channels called sodium, potassium, 2-chloride channels. So these channels, from the luminal side of the tubule, it will shift the tube from there to the interstitium. Interstitium is the supporting tissue. So the tissue surrounding the tubules is called interstitium. So if you see the picture of a nephron, you will understand thin descending limb is there and thick ascending limb is there. In between this, there is the interstitium or medullary interstitium. So when sodium potassium 2-chloride reaches this interstitium, it will increase the osmolality of the interstitium. In the osmolality or tonicity, it will increase the tonicity of the interstitium. So it will become hypertonic. When it becomes hypertonic, what will happen? It will draw water from the thin descending limb of loop of Henle. This glomerular filtrate is flowing down the thin descending limb of loop of Henle, which is permeable to water. So when the interstitium becomes hypertonic, this interstitium will draw water from the thin descending limb of loop of Henle, and that way it will absorb water. So that is how in loop of Henle water reabsorption is occurring. So which drug acts on, blocks this sodium potassium 2-chloride channel? It is blocked by loop diuretics. Loop diuretics, they are furosemide, torsemide and all. So it will block sodium potassium 2-chloride channel. So when the patient is having sodium potassium 2 chloride channel, so when in Bartter syndrome, abnormality is in sodium potassium 2 chloride channel. So it will get obstruct, what is it called, it will not, it is like Bartter syndrome is something like giving a loop diuretic. So what will happen, there is loss of sodium. A loop diuretic, what it will cause, any diuretic actually it causes loss of sodium plus water. Then it will cause loop diuretic when it blocks the sodium potassium 2 chloride channel. All these things are not absorbed by the body, by the tubules, so it will be lost in urine. So patient will be having loss of potassium in urine, loss of sodium in urine, loss of chloride in urine. All these things will happen. So because of that, patient will be having, then what will happen, there will be, because of hypovolemia, there is increase in mineralocorticoid, renin system will be activated. So it will stimulate loss of potassium again, and H plus also. So it will cause, so diuretics, one of the side effects is metabolic alkalosis, that is related to volume contraction. So patient will be having metabolic alkalosis, hypokalaemia. And in Bartter syndrome you will get, but there is no hypertension because there is loss of sodium. When sodium is retained only we will get a hypertension. Here there is loss of sodium. So since there is excessive loss of calcium also, that is hypercalcemia also is associated. So patient will have stone formation also. So when somebody is having renal stone with hypokalemia, think of this possibility, that is Bartter syndrome. Then just mentioning another reason for hypokalemia with stone formation is renal tubular acidosis type 1 or distal renal tubular acidosis. So in Bartter syndrome there is no hypertension, that all things are all right. There is hypokalemia, that also is there, but urine chloride is relatively low, it is not increased much. And also this Bartter syndrome presents usually little younger age than this 28-year-old. So Bartter syndrome also is unlikely. So the final thing is drug ingestion. So it will be some form of ingestion of drugs, especially diuretics. So when they take diuretics, patient will be having, they will be normotensive. So he is taking diuretically, normotensive, there will be hypokalemia, and because of the okay, that is why it is not, it is drug ingestion, that is diuretic ingestion. So the final answer is drug use, most likely some form diuretic.